The sclera and conjunctiva surround the cornea, and that is the next part of the eye that we're going to look at now as potential source for a red eye. We've already briefly talked about corneal foreign bodies as a cause for red eye, and these, once identified, can be very easily removed with topical local anesthetic. Sometimes you don't get any foreign body, but the corneal epithelium has been scratched. The eye is exquisitely sensitive to pain, and even the slightest abrasion, such as that seen here under blue light with fluorescein dye, can feel very uncomfortable. If you instill local anesthetic eye drops, you can diagnose this and treat it conservatively, sometimes with antibiotic drops. A more serious traumatic cause of red eye is chemical injury. And you would, of course, have some kind of history for a chemical splash. Alkalis tend to be worse than acid, but whatever the cause, you should treat it with immediate and copious irrigation, probably from a bag of normal saline. I would suggest 1 to 2 litres of saline should be instilled into the eye before you even do anything such as test the pH or examine the eye under the microscope. A common cause of eye pain in the early morning is recurrent erosion, whereby the basement membrane on which the epithelium sits has been disturbed, and the epithelium can be very easily rubbed off with minimal friction, such as when you're opening your eye over a slightly dried out cornea first thing in the morning. This is a slit lamp diagnosis, but with a very easily identifiable presenting symptom. We're going to move on to infectious causes of corneal disease now causing red eye, and we'll start with viruses. So the adenovirus, which is a common cause of the common cold, can cause corneal disease. These little nummular, small little nummular subepithelial infiltrates can be seen at the slit lamp, and sometimes with the naked eye with a little bit of magnification. But they cause glare and halos around lights at night in association with conjunctivitis. A more serious viral cause of corneal disease is the herpes virus, and it typically causes these fine branching ulcers which show up with fluorescein dye when you shine a blue light at them. They're branching because it is a neurotrophic virus, that is to say, it follows the nerves, the sensory nerves of the cornea, which are fine and branching like this. It's a very beautiful but awesome sight, and needs to be treated before that ulcer turns into a corneal scar. If you get a reinfection of the cornea, and remember that herpes viruses often just lurk dormant in the sensory ganglion for months or years before coming back, then the herpes virus can come back in the form of a deep stromal infection, the Disciform keratitis, where you can see there's a cornea is a bit thicker here, and you might see a vague cloud-like opacity with some white keratic precipitates on the back of the cornea. Bacterial forms of corneal infection are much more serious, remembering that the cornea should always be crystal clear, and if it is not crystal clear, then you should be prepared to act swiftly to diagnose and treat the cause of that opacity. So this is a typical bacterial keratitis causing a creamy infiltrate at the edge of the cornea. Here's the conjunctiva, and here is some abnormal blood vessels going up to that infiltrate. At its worst, you can get a whole abscess filling most of the cornea. You can see here that the epithelium has been lost, so you've got epithelial defect and a stromal abscess. Here also, filling the anterior chamber, is a fluid level of white blood cells, a so-called hypopion. Once this has been diagnosed, it is treated with intensive topical antibiotics, hopefully before the cornea perforates, because if the cornea perforates, that may well be the end of the eye, or certainly of the eyesight of that eye. Another cause of red eye caused by corneal infection is Acanthamoeba keratitis. Acanthamoeba is a protozoan that is present even in treated tap water. If it is allowed to get into the cornea, it causes exquisitely painful scarring condition, such as that seen here. And the clue for this is in the history of contact lens wear, particularly if the patient has not been employing scrupulous hygiene with their contact lenses and, for instance, have been rinsing either their eyes or their contact lenses in tap water. Behind the cornea is the anterior chamber, full of aqueous humour. The anterior chamber is normally crystal clear and free of white blood cells and inflammatory chemicals. But if the blood-eye barrier is broken down by an autoimmune disease, then you can get uveitis. Now, the terminology here is difficult because you will sometimes hear uveitis, iritis, and anterior uveitis used for exactly the same thing. They all just mean an inflammation of the front of the eye. The symptoms are of photophobia, that is exquisite pain on exposure to light, and a deep aching pain. Under the slit lamp we can see white blood cells and proteinaceous exudate. You might see that the iris has been stuck down in a petal-like formation to the lens behind it. This needs steroids and dilating drops, but is a slit lamp examination. As non-ophthalmologists, you will just need to be able to suspect it with the history of photophobia, deep-seated ache, and possibly an abnormal shaped pupil. Behind the cornea is also the drainage angle of the anterior chamber. That is the gap between the cornea and the iris behind it. If that gap is narrowed, maybe due to enlargement of the lens or expansion of the iris muscle, then the gap in which the aqueous fluid drains gets blocked off and the pressure rises precipitously to cause angle closure glaucoma. Angle closure glaucoma presents with a headache, and sometimes the redness of the eye is overlooked in favour of the more dramatic headache and vomiting that might lead you to look for an intracranial cause of the headache. However, you should always look at the eye to see if it is red in the case of headache. You can see at this slit lamp photograph that the cornea, that's this white line here, is very close to the iris, that's this orange-brown line here, and that is the hallmark of angle closure glaucoma if you have access to a slit lamp. If you do not, then you should be guided mainly by the symptoms of red eye, vomiting, headache, halos, and reduced vision. The pupil is often semi-dilated, it's not perfectly round, and won't react to bright light. It's treated with making a tiny little hole in the iris, usually with a laser. Finally, you can get an inflammation of the whole of the eye called endophthalmitis, and the most important cause of endophthalmitis is post-operative endophthalmitis following cataract surgery. The eye tends to be sore. The vision, having previously been good, can become very poor, and you need to suspect it if the patient gives a history of recent cataract surgery in the last week or two. Having tested the visual acuity and found it to be poor, you may find that there is a fluid level of white blood cells contained within the anterior chamber, a so-called hypopion, in addition to the red eye. That needs an emergency referral to the eye department so that we can treat it with antibiotics, both topically but also injected directly into the eye. So in summary, there are many causes of red eye, and you should consider an anatomical as well as etiological classification of red eye. From front of the eye, affecting the eyelids, to the conjunctiva, to the episclera, to the cornea, to the anterior chamber, and finally to the whole eye. Thank you very much for your attention.